Hello, everyone. My name is Raquel Wallace, and I am the National Manager of Programs at the American Liver Foundation. I would like to welcome you to today's webinar made possible by the generous support of Alexion Pharmaceuticals. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients with liver disease and their families through education, support, research, and advocacy. I would like to thank Dr. Jeff Bronstein, who will be sharing his expertise on today's webinar. This program will be discussing some key information that everyone needs to know about this rare disease. This webinar will also provide guidance and education on the causes, symptoms, diagnosis, and treatment options available for Wilson disease. We will also have Virginia Kiser, who is our patient speaker for today, to provide her story and patient experience. Some of today's topics will include symptoms, initial signs of the disease, diagnosis, daily challenges, dietary issues, and disease management. Before we get into the content for today, let me just start with a few housekeeping items. On the upper right-hand part of your screen, you should see a dialog box. If you don't see it, there is an orange arrow you can use to expand the window. From here, you can ask questions. You can ask questions at any time, and we will be answering them in the last 10 to 15 minutes of the webinar. We will get to as many questions as possible. We welcome your participation, so please do send your questions in. I would now like to introduce our physician speaker, Dr. Bronstein. Dr. Bronstein received his bachelor's degree from the University of California, Berkeley, and his MD and PhD from UCLA as a recipient of the Medical Scientist Training Program Award. He completed a residency in neurology and fellowship training in movement disorders at UCLA and at Queen's Square in London. Dr. Bronstein also completed a postdoctoral fellowship in molecular biology before being appointed an assistant professor of neurology in 1994, director of the movement disorders program at UCLA in 1996, professor of neurology in 2006, and professor of molecular toxicology in 2007. His clinical interests include the medical and surgical management of Parkinson's disease, Wilson's disease, and other movement disorders. Dr. Bronstein runs an active research program that includes clinical trials to develop new therapies. He also directs a basic science laboratory investigating the causes of Parkinson's disease, environmental and genetic, using cell and zebrafish models, as well as population-based studies. Without any further ado, I now present our speaker for this webinar, Dr. Jeff Bronstein.
Thanks very much. I'm really happy to be here. I'm just going to talk a little bit about, give an overview of the disease, some of the clinical manifestations, and the treatment approaches. Now, I'm a little different than most of the Wilson's doctors out there, which are more hepatologists or liver doctors. So I have a little bit of more of a neurologic viewpoint, and the patients I see tend to be skewed towards neurologic patients. So I'm trying to get control of the next slide. Let's see if that works. Okay. So the prevalence, it's a pretty rare disease. It's autosomal recessive, which means you need to have 2 copies of a mutated gene to actually get the disease. It's pretty rare, as I stated, but if you look at large populations, there should actually be more patients with Wilson's than we generally see. And we're not sure exactly what this is, whether some people actually don't get the disease even if they have 2 copies, which is called reduced penetrance, or more likely, there are many that are out there that are undiagnosed, which is obviously a big problem and why we need to get the word out. Most people present in the teens and early 20s, but people can present below the age of 5 and after the age of 50. They're much rarer, but it can happen. When people get it younger, they tend to present more with liver problems than with neurologic problems. Now, they can present in many, many different ways. It depends a bit on the age uh, and sensitivity. Some people present with liver disease. Of course, I usually don't see those people early on. I see the people that present mostly with a movement disorder, but often they had had some sort of psychiatric problems, which I'll talk about in a few minutes, even before the movement disorder or the liver disease started. I do want to mention there's a few typos and misspellings in the slide, so I apologize for that. So males and females get it about the same amount. There's no real gender bias. Um, Thought maybe the males have more psychiatric problems than women, but it's not really very clear. Um, we do know that by definition now, Wilson's disease is caused by a mutation in a gene called ATP7B. I'll show a picture in a minute what this looks like. And you need a mutation in both copies. Now, they don't have to be the same mutation, and often they're different mutations, but they need to be a mutation in each copy to get the disease. Now, the clinical presentation really, again, varies. Now, I have a list on the slide of the different sorts of movement disorders we see. There's that smile that we often see. It's kind of, we call this a dystonic smile or a rhesus sarcoidosis, excuse me. But people can either move too much, which we call hyperkinetic movement disorders, or too little. They're called akinetic rigid syndrome. They have Parkinson features. I would say most people, majority, have some dystonia, which is really a contraction of muscles working against each other. So it's called agonist and antagonist, and they're kind of fighting each other, and people get these abnormal postures, which are shown in that slide. This is kind of the percentage of types of symptoms that people get based on several series. And so there's huge ranges, but you can see that dysarthria or poor speech is really, really common. Problems walking due to kind of ataxia, that's what people look like when they're drunk, is a pretty common, and dystonia are very, very common. Tremors, we see all kinds of tremors. There's various types. Seizures are a lot less common, but they do occur. And problems swallowing can occur in many people as well. So you can see almost any neurologic problem, and this is often why people get confused with the diagnosis. It doesn't present in just one way. Sorry, I'm having problems advancing. There we go. Okay, so this is what we call a hyperkinetic movement disorder, where he's a child that you see is moving too much. We have lots of ways of describing this in movement disorder circles, but just I think it's pretty obvious he's moving too much. It's a little bit broken up. It's usually a little smoother, a dancing type movement, which we call chorea, and he's got repetitive actions, which we see in some of these kids as well. So it can be quite devastating. So one of the biggest things that we see is psychiatric problems, and they occur in 2/3 of all patients, and in about 1/3 they actually had symptoms of this at the beginning. So, and it's really not uncommon, since it happens around the late teens, that somebody, I've seen this story multiple times, where somebody will go to college, get depressed and anxious, and it's thought to be just a major change in their life. Going to college, they come back, they get put on an antidepressant, Maybe it gets a little bit better, but then they start developing a little tremor, and they say, well, that can happen with antidepressants. And you can see how this could be missed if people are not on the lookout for it. And it's only till the liver problems or more serious neurologic symptoms occur. This is clearly due to some deposition of copper in the brain, and it's often the first symptoms. And then, unfortunately, it's commonly missed. And it's in defense of the people that miss it. Depression is pretty common, and anxiety is pretty common in this age group. So you can't look for it in absolutely everybody, but you definitely need to keep it in mind, and screening needs to be much more common. Depression, again, is the most common thing we see in anxiety. The liver involvement can really vary, anywhere from asymptomatic abnormalities in some of the blood tests of the liver, or people can present with complete liver failure, with bloating of the stomach, turning jaundice. So it just depends on how well people are, how often they're going to the doctor, and how fulminant the disease is. You'll hear a lot about what's called the Kiser-Flesher rings, which is a picture there with the arrow showing it. I have seen a lot of Wilson's patients, and almost all of the patients I see have neurologic problems, and almost all of them will have KF rings. I will tell you, without a special exam called a slit lamp exam, it can be very difficult to be certain. And even then, if the ophthalmologist is not trained, they can miss this as well. So if it's clearly there, especially with a knowledgeable ophthalmologist and a slit lamp exam, it's very strongly associated with Wilson's, and there's virtually nothing else that will do this. But again, it can be very, very difficult to be sure. So I don't use this, especially my exam, to confirm or rule out Wilson's, although it's something we definitely consider and look at. Now, this is a slide just depicting the ATP7B protein. And for those molecular people, you can see there are 8 parts of the protein that go through the membrane, and this is mostly in the liver. I think the point of it, of the slide for this group, is that it's a very large protein, and there's been over 500 different mutations in this gene that have been shown to make it not function right and cause a disease. So these mutations can be anywhere. In a little more graphic formulation, on the left, you can see what we call normal copper metabolism, and those little blue arrows are a normal ATP7B protein. And so what happens is copper, which is shown in the gold, it gets transported in through a copper transporter. Once it gets into the liver cell, it quickly gets accumulated in it's called the endoplasmic reticulum, shown in brown, and the Wilson's protein gets all of that copper in there, which then binds to a protein called ceruloplasmin. Then the ceruloplasmin is either excreted through the bile, which comes out in the stool, that's shown in those little green vesicles, or it gets released in the blood, tightly bound to ceruloplasmin. When you have a mutation in Wilson's disease, the copper does not get excreted properly into the bile because it doesn't accumulate into the ER, which means the ceruloplasmin never binds to copper, or rarely does. And what happens is the ceruloplasmin gets broken down very quickly. So this is the reason why people have excessive copper in their blood but very low ceruloplasmin, because the copper really doesn't stay in the blood very well unless it's tightly bound to ceruloplasmin. So if you don't have enough ceruloplasmin, you're going to have more free copper. The total copper in the blood is actually lower, but the free copper, the unbound copper, is what's elevated. So in the routine blood tests of copper, it's low in Wilson's disease. And it's only after you do a calculation of the free copper that shows that it's elevated. It's the elevated free copper which allows it to get into the brain and do its damage, cause the neurologic problems. Now, the diagnosis is very difficult based on clinical grounds alone. Any kind of liver disease, you have to think about Wilson's as a possibility. You can get abdominal pain, bleeding, jaundice, turning yellow. And I think we already talked about the central nervous system, the neurologic problems. It can be almost anything, so it's very nonspecific. And you can get your red blood cells can lyse, called hemolysis. You can have low platelet counts, called thrombocytopenia. And the only specific clinical feature are the KF rings, which I just talked about. Sorry, I keep getting a delay when I try to advance the slide. There we go. So on routine blood tests, on somebody with Wilson's, it can be absolutely normal. The cell counts can be normal, but often there'll be an anemia or low platelet counts. That's very common, but again, very nonspecific. We often see abnormal liver tests. And again, those are nonspecific as well, and they can be mild, just showing a little bit of increase in the liver enzymes, or we can see increased bilirubin, which gives you the jaundice. The liver, if it's not functioning properly, can cause excessive bleeding because you're not making enough of the clotting factors. So again, all of these are nonspecific, so them by themselves would not lead you to Wilson's, but should lead you to consider Wilson's as a diagnosis. The specific tests are low ceruloplasmin, and a very low one is almost diagnostic for Wilson's, or strongly suggests it. If it's a little bit low, you have to consider some other things, which we'll talk about. But a low ceruloplasmin with KF rings, it's Wilson's disease. Now, other things can cause low ceruloplasmin. So the most common one we see is somebody with a carrier for Wilson's. In other words, they only have one copy. And so one copy is enough to be able to get that copper into the endoplasmic reticulum and to keep people from getting disease. But their ceruloplasmin may be around 15. Sometimes I've seen as low as 12 or 13, but they're just a carrier and there's no problems. People that get hepatitis from a virus can have a low ceruloplasmin. Usually that comes back. People with injured liver from chronic hepatitis can have a low ceruloplasmin. People with alcoholic cirrhosis can have it. And other things like losing proteins through the kidneys can have it, called nephrotic syndrome. And then there's some other rare diseases such as Menkes disease, which is actually a disease that happens almost exclusively in boys, where there's actually a defect in the transporter that gets it into the liver cell. So these other causes are less common, and with a low ceruloplasmin, you definitely have to strongly think about Wilson's disease. One of the tests that we rely a lot on is a 24-hour urine copper. If it's almost always above 100 in untreated patients. It goes up even higher when you treat patients, and I'll talk about that in a minute. And it's almost always above normal, above 50 or 75 in a 24-hour period, if it's collected properly. So there's always instructions for those of you who have done this test, there's very specific instructions that have to be followed. Otherwise, it'll come out abnormally low and it'll give us a false reading. Genetic testing really has come a long way since I started in this field a number of years ago. We used to just test for the most common mutations, but now there's much more reliable sequencing. It's called exon sequencing. It's quite reliable, and it's not quite 100%, but pretty close to 100% now. And when you know the mutations, it makes it really nice for screening for siblings. So anybody that has a brother or sister with Wilson's needs to be tested. And if we know their mutations, you can just do a blood test for those mutations in yourself. And that would alleviate the need to get all the other blood and urine tests. Now, liver biopsy is done much more commonly by hepatologists. I've never done a liver biopsy, and I will sometimes refer patients for liver biopsy. It can be very useful, especially in questionable patients. I think it's happening less and less now, but it's still quite common. And if it is a lifelong diagnosis, it's hard not to want to be as sure as possible. And basically, what you're looking for is too much copper in the liver, and I could provide some cutoff values that people use. It's a relatively safe procedure. It also gives you some information on the amount of liver damage, although other tests can do that now. Ultrasounds, different types of ultrasounds, for example. But it's still a very common procedure that's done by the hepatologist and can be very useful. But again, not everybody has to have it, especially now with genetic testing being so readily available and so accurate. Brain imaging, is something that we use all the time. If you don't have neurologic symptoms, I don't think it's absolutely necessary to get an MRI, but we like to get it to see if there's any evidence of brain damage. It is I'll show you a bunch of images in a minute, but it can be almost anything. Copper doesn't show up on MRIs, but the injury from the copper accumulation in the brain does show up, and that's really what we're looking for. Now, it can improve after treatment, but it really doesn't help us manage the disease. We go by clinical improvements or deterioration, and we go by lab values. So I routinely don't get follow-up MRIs later on. It's really to help with the diagnosis and kind of the extent of the neurologic involvement. And I'm just going to show you some MRIs that I've taken from the literature. So those arrows are showing these are deep structures called the basal ganglion, and those are the structures that cause the abnormal movements. And those white areas that you see with the arrows are pointing, that's abnormal, showing basically inflammation in those parts of the brain, and you can see that it improved 3 years later after a successful treatment shown on the right. So that's a very good, optimistic report. Now, these are some other images showing much more extensive disease, and so you see all that excessive white. It's just a huge range of MRIs. So a lot of times radiologists and neurologists will see some of these pictures, and I give this talk to lots of people just to show that just because it doesn't have what we consider the typical pattern that we see in Wilson's disease, you can see almost anything. Here's some other ones, and these are quite severe cases showing in different parts of the nervous system. Now we have we call diagnostic scoring criteria that was published 18 years ago. And basically, it's a way for us to come up with a diagnosis. Either it's almost certain, um, likely, or possible. And you can look at this later, but it includes evidence of KF rings, neurologic symptoms. The serum ceruloplasmin you can see is very important. You need to score a 4 for definite uh, uh, diagnosis, and you get half of that just from the ceruloplasmin alone. You can also notice if you have genetic analysis, that's enough. You can get a score of 4 just from that. You get 2 points for abnormal copper in the urine if it's too much, and a liver biopsy also can give you 2 points. So you can see there are many ways to come up with a diagnosis, but the most specific is mutations in genetic analysis, and I think more and more this is becoming the standard of care. Now, treatment. That's probably the most important part once you make the diagnosis. And overall, you just have to think of that you want to excrete, you want to get rid of more copper than you take in. So we want to reduce the amount you consume, and we want to increase the amount that that you take in, or increase the amount that you excrete or you get out of your body. If people are asymptomatic and you've just found that you had the mutations because of a routine test was slightly abnormal, or a sibling had it, you can treat with zinc alone, and I'll talk a little bit more about it. But if people are symptomatic, we usually chelate, which is to help reduce, help to bind the copper, pull it out of the liver, and get it out of the system faster, where zinc just blocks the amount you absorb. So there's some general guidelines that we like to state. Again, these are general. For those of you who have it, you probably know this, and the foods very well. But overall, you want to limit the copper intake to less than 1 milligram a day. But if you think of it overall, you might do a little bit more one day, a little bit less the next day, especially when you've established, you've been adequately chelated. In the long run, you've learned how to do this and how to overall keep it around 1 milligram a day or less. So you want to avoid mostly the foods that are high in copper, and things like copper, water in the pipes. We have copper pipes. You want to run the water for a little bit and clear the pipes to lower it, or use purified water. The regular filters that people use that you can buy over the counter do not get rid of the copper. You really want to use distilled or purified water if you really want to have very, very low or no copper in your water. So foods to eat are things like most of the poultry. The white meat is better. Fish is good. Some of the beef is good, but not the organs. Almost all the vegetables and fruits are good. Bread, cereals, dairy are all fine. But you really want to stay away from liver, organs, nuts, beans, mushrooms, and bittersweet chocolate. So it's a tough diet for vegetarians, but it's very doable for most people. Now, the medications are obviously play a very important role, and most people are symptomatic when they get diagnosed. So we have three drugs that are actually FDA approved in this country. It's actually recommended to start with penicillamine, which many of us don't. We use trientine, mostly because there really hasn't been fantastic trials for these. They've all been kind of open label anecdotal trials. Both of them bind the copper and help you get rid of it. It's called chelation. The problem is that when penicillamine and trientine, maybe to a little lesser extent, when they bind it and pull it out of the liver, it actually can transiently raise the free copper in the blood. And so some people with neurologic problems can actually get worse as they're being chelated, and their neurologic condition can get quite severe quite quickly. So for this reason, we start very low doses with people with neurologic symptoms and then work it up slowly to avoid this from happening. But this can happen anywhere from 25 to 50% of the time. Some people, especially in the U.S., believe trientine does it less than penicillamine. Penicillamine clearly has more common side effects, rashes and fevers, things like that. We see less of that with trientine. So most of us here start with trientine, the ones that see a lot of patients with it. As you probably know, those who have taken it, the company that bought both of these drugs made them incredibly expensive, from $200 a month to I think it's about $28,000 a month now. So it's highway robbery. But unfortunately, that's really all we have on the market right now for chelation. Fortunately, zinc is available for asymptomatic people, or if you're very mildly affected, you can go right to zinc sometimes. Now, zinc, what that does is it increases a protein in the lining of the intestines, and it binds the copper so it doesn't get absorbed. So this is a way it helps keep you from basically taking in more copper. So the negative copper balance is established, but it's a lot slower than with chelation. It's quite inexpensive, usually well tolerated. There's a couple different formulations, but all of these medications have to be taken on an empty stomach. Which can be an annoyance for people, especially when they're taking it 3 times a day. Teenagers particularly are hard to keep them on the diet and also taking these drugs, although you can see how important it is. We're now testing a medication called tetrathiomolybdate, or TM. This also is a chelation, but it binds directly to copper with albumin, so it doesn't raise the free copper. And at least in the early trials, it doesn't cause the neurologic deterioration, or if it does, it's very rare. It's once a day, so I think if this gets approved, it's going to be a big advance. Now, we've been part of a couple trials with it. We're ongoing trial right now, and so far it's gone quite well, but we'll have to see. We're in a blinded large phase 3 trial right now. You'll hear a little bit about this from somebody with firsthand experience, but liver transplant cures Wilson's disease. Liver transplants become quite remarkably safe, although there's a slightly lower survival rate in Wilson's patients. This also may be how sick they are when they have the transplant. It doesn't necessarily reverse neurologic deficits, much like chelation. If there's damage done, you can't reverse the damage. So the idea is to try to prevent the damage from happening. Obviously, if you get a transplant, you're on immunosuppressive drugs, which is a negative problem, but it can be quite a good treatment for some people. We monitor both by urine copper, which is my favorite thing to monitor because the calculations for free copper in the blood tend to be pretty inaccurate, and you can overtreat. Low copper can cause neurologic problems as well. We also have to keep an eye on the platelets and the liver function tests as well and treat it appropriately. Now, if you catch this early, the prognosis can be very excellent. People have to be compliant. They have to keep on their medications, and they have to eat proper diet. If you don't, it can be fatal, and severe neurologic deterioration can occur. without treatment, or if people are chelated too quickly. I've seen some horrible stories where people have really done so well for so many years and then they become non-compliant, some became homeless for other reasons, and they just have a horrible outcome, and it's just a terrible thing to happen because it's completely preventable, at least in the vast majority of people. So at that point, I'm finished with my presentation, and I'll take questions as Virginia finishes.
All right, thank you very much, Dr. Bronstein. I would also like to take the time to highlight Rhonda Rowland, who has joined this webinar with us today in support of today's program. Rhonda was diagnosed at age 21 after going into liver failure. Her Wilson disease diagnosis was confirmed by the presence of KF rings on an eye exam. And after medical intervention, her liver function improved and she has maintained good health for the past 36 years. And so now we will hear from our patient speaker, Virginia Kiser, and after which we will begin our Q&A.
Hello, and thank you so much for having me today. I've actually just learned a ton myself about Wilson's disease that I didn't even know being a patient of this. So this has been a really good webinar, and I'm excited to share my story. So my Wilson's disease story started in the summer of 2007. My 17th birthday was just over a week away, same day my senior year of high school was supposed to start. Throughout the summer, I hadn't been feeling my best. A trip to Hawaii with my grandmother resulted in me spending most of the time singing to the porcelain gods in the bathroom. But my primary care doctor, basically without running any tests, just chalked it up to me being a teenager, kind of what Dr. Bronstein was speaking to, and had diagnosed me with mononucleosis without running a test. So in August, I had my senior photos taken, which was on the previous slide, and I had to cut the shoot short because I couldn't keep food down. By the next morning, I was having waves of pain hit my stomach like I was being punched, and most significantly, my urine was basically almost black. My mom rushed me to our nearest emergency room, and I can't tell you how many MRIs and CTs and blood tests I did. We'd been there most of the day with a ridiculously high white blood cell count, but no answers. And at some point, a doctor came in the room. He turned off the lights and said, "I doubt it, but I just want to see something." And he shone a light in my eyes, and my mom gasped. There they were, Kiser Fleischer rings. They could be seen by the naked eye, but as Dr. Bronstein spoke to, it takes a lot to be very, very certain of Kiser Fleischer rings. So at that point, Wilson's disease didn't come up. In fact, they were concerned my gallbladder was the source of a problem. So I was transferred to another hospital to have a laparoscopy done. My parents said it was like a couple of minutes before the doctors came out and showed them a picture of my liver. My mom described it as though someone took fishnets and put them around my liver and squeezed and then colored all the little bubbles in with a black Sharpie. The doctors said it was cirrhosis of the liver worse than an 80-year-old lifetime alcoholic. And it took the doctors another 24 hours to confirm end-stage liver failure from Wilson's disease, which at the time they hadn't confirmed but believed I had inherited the recessive gene from both of my parents. This was later confirmed through liver biopsy, blood testing, and genetic testing. But at that point, it had been maybe 48 hours since I first went to the hospital, and I was already unable to walk anymore, and I was going in and out of a conscious state. Fearing that I wouldn't survive a flight to California because they wanted to send me to either Stanford or UCLA, Oregon Health and Sciences University in Portland, Oregon, which is my hometown, actually took me on as an adult patient since my 17th birthday was so close, and I was 5'9", so I was basically big enough to get an adult liver if it became available. From there, it was a waiting game, but it was a clock working against me. By the time I was transferred to OHSU, doctors estimated I could survive less than a month without a liver transplant, and 6 days after that estimate, it became less than 48 hours. So August 28th was the day I got sick. September 10th was the day I had what some called the golden hour. I suddenly woke up. I felt like I had a ton of energy. I got up. I walked around the hospital. My parents brought me pizza. I ate 2 whole slices. I'll never forget it. It seemed like I could make it a few more days, maybe even weeks. But just an hour after that pizza, I saw it again, and I was bedridden again. And sorry, every time I tell this story, it comes back. But I was actually suffering from hepatic encephalopathy, and I had reached coma stage. So doctors were weighing whether a shunt would buy me more time, and my parents prepared their device because no one expected me to make it the next day. And then it happened a couple hours later. It was like a Lifetime movie. I remember the parade of white coats coming in. It's the last thing I remember, just doctor after doctor after doctor. And the words, "We got a liver. It's in Seattle. It's on its way." I woke up the next morning for the transplant, and I was up walking within a few hours. I really didn't know what had happened, but I felt completely normal by the next day. I was told with Wilson's disease, doctors really didn't know what my outcome would be. There was and still is just such little information available on post-transplant Wilson's disease patients. But they told me not to expect a normal life. College would likely be out of the question, that I would just need to spend my life caring for myself. So I took that challenge and I went home 6 days later. I was back in school full-time by mid-October, graduated following year, and then went on to the University of Oregon, where I got my bachelor's degree. And now I work as a financial assistant. This past summer, I got married. And a few years ago, I got the chance to speak alongside Senator Merkley from my state of Oregon to help protect the ACA. And I'm hoping to work more with him on prescription medication prices legislation in the future. And last year, it really hit me just how amazing it is to still be alive when I met my niece for the first time. So I've gotten almost double the life, all because of the donor. And but my Wilson's disease story is very, very unique because it wasn't until I was in need of a transplant that we even knew what this disease was. And now I'm searching for answers as a post-transplant patient and find that we're a very rare bunch. So this webinar has been just a wonderful opportunity for me to share and learn as well. So thank you so much for letting me share my story.
Thank you so much, Virginia. I'm sure a lot of our participants today have received some insight on the patient experience as well as others. This pretty much just lets them know that they're not alone. And so at this time, we do have some time for some questions. So we're going to go right into those now. Our first question will be for Dr. Bronstein. This is more of a specific case, but in general, her son received a liver transplant, but he's still struggling with anxiety and depression, and she never met with a neurologist for his condition. So she wants to know if this could still be some type of neurological issue that was derived from Wilson disease.
Yeah, so obviously I don't know the specifics of your son, and I'm sorry you've had to go through this. But I will say in general, so it is very common for people to have some anxiety and depression just from going through this whole experience. I mean, having a liver transplant, as you heard, is not, just a minor event in somebody's life. So having the disease and stuff can give a certain amount of anxiety and depression. Now, often it's not clear whether it's directly caused by involvement of the nervous system or not. It can be, and it's actually quite common. So I think more times it is a reflection of some injury to the brain. Now, neurologists unfortunately don't have any magic cures for that, and so we treat anxiety and depression the same way, whether it's due to neurologic involvement or not. So you want to be working with somebody who's experienced with treating anxiety and depression. Often it's a psychiatrist with or without a psychologist, or vice versa. Many neurologists like myself feel pretty comfortable treating it, at least to some degree. So I think once people have involvement, I think of treating the disease in two ways. One is restoring copper balance to its proper level, and that's done by medicines and food, as we discussed. And then there's treating the symptoms that were a result of the disorder, and that's using counseling and medications. And it takes a while. I mean, it can take, we usually say it's up to 3 years we see neurologic improvement once treatment has been initiated. So people have to be patient. The brains are plastic and can heal themselves to some degree. But there's nothing magical that a neurologist can do other than treat the symptoms. That's why we try to get it early.
Thank you. Another question that was asked was, is there current research that is going on to help parents give their kids medicine that doesn't require them to take it on an empty stomach?
I will say the closest thing is tetrathiomolybdate, which still needs to be taken on an empty stomach, but it's just once a day. These studies are fairly far along, so I'm hoping it's not too far in the future. The research I think that's most promising to avoid medicines altogether is gene therapy. So you just need to get the gene for a functional protein in the liver. We now have the technology to do it, and there are efforts to bring this to clinical trials. I will tell you, it will be a while before it's available as a general therapy to everybody, but I suspect the trials will be starting in the not too distant future. So I think the gene therapy is going to be the most likely choice to completely eliminate the need to take medicines on an empty stomach.
Thank you. The next question, how long does it take to receive liver biopsy results?
It varies from lab to lab and place to place. Usually we get it within a week here at UCLA. Virginia, how long did it take to get yours, you know?
I mean, I can tell you when they were trying to diagnose, it was within 24 hours. And post-transplant, I had 2 more biopsies. I had 2 minor episodes of rejection that were just treated overnight. And I know that they had those biopsy results before I left the hospital the next day.
So it does depend on what you're looking for. So when you're transplanted, they're looking for rejection, inflammation. So for the diagnosis, they're looking to quantitate the amount of copper. That usually takes a little longer. Just looking for scarring and things like that can be done pretty quickly in a day or two. But usually, at least here, it's been about a week to get the quantitative place. Some places don't have it in-house. They have to send it out, and it can take a little longer.
Thank you. So there seems to be, I guess, varying opinions in terms of the copper diet, seeing that there are some medications that would remove the excess copper. Is there other scientific evidence that would pretty much support that a low copper diet would help to make a difference?
Yeah, so it's interesting because I have reviewed the research on it is actually quite sparse. It's really based mostly on common sense, which is if you eat less, you absorb less. And when you see how horrible the symptoms can be, if you accumulate too much copper, better safe than sorry. So I personally think, keeping to a copper diet makes sense, but not especially once you've reached a stable place where your copper balance is good. I think probably you can be a little bit looser, but I wouldn't advise it because it's a slippery slope, and it varies from person to person. So, for example, zinc induces expression of this protein to bind the copper, but we're all different. It induces it more than in some than others. So you're going to have some people that can be really loose with their diet and have no problems, and other people are going to have problems. And I have had plenty of patients where I'll get their 24-hour urine copper come back and their blood levels, and I say, hey, what's going on? You've been fine for 6 years, and all of a sudden it's doubled. I said, yeah, I wasn't watching my diet very well for 6 months, and so to me, you're really risking it in the long run. But if you want to be hardcore scientific, there is evidence that it makes a difference, that it's there, but it's not as robust as I would like to see it.
Thank you. Also following along the lines of the diet, is salmon and leafy greens other food options that should be removed from the diet?
I'm not 100% sure specifically. In general, fish and all vegetables are good. I'd have to look up salmon specifically. I think it's fine, but I wouldn't. I don't know the whole list off the top of my head. Sorry. Maybe Virginia, do you know?
Yeah, the diet is something that was never a factor in my life, again, because I didn't get diagnosed with Wilson's disease until I was 2 weeks pre-transplant. But I do know that I ate a lot of salmon growing up, and I still eat it. I eat it on a weekly basis. And I do remember the doctors mentioning something along the lines of my diet may have had an influence on the amount of copper in my system, but I can't speak to it with 100% accuracy.
And you have a normal liver now, so you can eat anything you want. So.
Yep, that is, and so the only thing I maintain now is transplant medication. I take an immunosuppressant called Prograf, and that's it. I do not have to treat the Wilson's disease. I can't eat grapefruit because it interacts with Prograf. And I have some other kind of metabolism issues that may or may not just be related directly to the physicalness of having the transplant and all the nerves and everything kind of being shuffled around. I have a lot of times with like highly acidic foods, but I don't know that it's necessarily Wilson's disease. It is more just the physical nature of the transplant.
Thank you. This next question is for Virginia again. Did you have an existential crisis post-op?
That's a great question. Yes and no is a great way to answer this. Kind of going back into the first question, so I'm 12 years post-transplant, and I am currently in therapy. My depression and anxiety is very, very high on a daily basis for me, and it felt like this past year it got even higher, whether or not that was external forces in my life influencing me. I tend to talk about my transplant almost like it happened to another person because it was so quick. And it was 11 days from the day I was diagnosed with liver failure to the day I got a liver transplant. And on day 12, I more than likely would have passed away. And so, yeah, I do have that existential crisis, but it's almost as if my brain won't actually allow me to process it. And I think this past year, I have been getting to that point where I can actually process what happened to me a little bit more. And I'm going through that in a bit now, but I'm working in therapy, and I'm really happy with the improvements I've been able to make in the past few weeks, especially. And that's actually what led me to this webinar, was trying to find more sources and resources for me to be able to work through those moments like that.
Thank you. This is for Dr. Bronstein. Will the current patient registry study help answer the question as to why some people went into liver failure as a result of being halted with medication, as opposed to later on now, things may move a little bit quicker?
Yeah, it will definitely help. I mean, it's not going to be answer all questions, because why people get the disease and more liver disease, and some people get more neurologic disease, some people present with liver failure as Virginia did, or other people with less problems. there's a variety of factors. There are other genes that do it, and the registry will help us with that if we have the DNA from those people. There are lifestyle factors. Some of that are captured in registries, diet, things like that. And then there are going to be other things that we won't know about. What other exposures? So it's going to be very, very helpful, and I think it is very important to move forward. Um, there are efforts as well, not just with the registry, but to develop a test. So when babies are born, they're screened for a whole bunch of rare diseases, and to add Wilson's on that blood test, or there's evidence that may be possible. And so we would hopefully be able to diagnose Wilson's actually at birth and prevent all of these problems. So I think that would be another important step along with the registry.
Thank you. So one person was saying that their son was never collated after his liver transplant. Is this something that should have been done?
Again, you don't know in the situation exactly, but in general, the liver, probably not. The liver transplant fixes it, and you help get rid of the copper very quickly with the liver. But it depends on a lot of specifics. But in many cases, it's not necessary.
Thank you. We just have a time just for a few more questions because we are running really low on time. Pretty much, this is for Virginia. How do you feel? This may be a little personal. How do you feel having to live daily with medication at this time?
This question is a very interesting one for me to answer because as I've learned more about Wilson's disease, I feel so lucky to only take Zolgraf on a daily basis, and I don't have to watch my diet. I get to basically just live my life. I have a timer that goes off in my phone every day, and it has for 12 years as a reminder to take those pills. But when I had my transplant, I started on 55 pills a day. I think it was something like 14 different medications, and I now take one medication. So I just consider myself so lucky, and it became very quickly just a part of my daily routine life. I wake up, I brush my teeth, I take pills, and I don't think twice about it anymore. I think I more think about the price of that medication every time I take it and how lucky I am to have access to it, and that's what's led me to work with Senator Merkley and trying to pass legislation to get medication prices down. Because I think about, I don't know what my family would do if I had Wilson's disease and had to pay for these medications, like the penicillamine, out of pocket. We probably would have moved to Canada. My dad says that often.
Thank you. There were a few more questions, but for the sake of time, as well as simply that some questions are a little personal, so I would even recommend, and I'm sure Dr. Bronstein can endorse this, it's better to consult with your healthcare provider, whether that's a hepatologist or a neurologist, just because he's not specifically working on your case, so it may be a little bit difficult for him to be able to answer certain questions. So as of this time, once again, Dr. Bronstein, thank you so much for your time and your love for sharing this needed information. We'd also like to thank Virginia for being a true patient advocate along her journey and being willing to include us as she embarks on this journey. Also, thank you to Alexion Pharmaceuticals for supporting this webinar. If you guys have any last closing words, Dr. Bronstein, if you have anything else that you'd like to say, you can share it at this time.
Yeah, I just want to thank everybody, thank Virginia, and I thank her for mentioning the legislation. There was actual congressional hearings led by Senator Susan Collins about the prices of medications, and we were hopeful that there'd be something done. But unfortunately, even after Valiant testified and all this after all their testimony, they turned around and increased the price even more. So hold your legislators to the grill to make something change. There's just this is Wilson's disease may be one of the worst cases of how some pharmaceutical companies are exploiting patients.
Thank you. And at this time, we will bring this webinar to a close. And on the behalf of ALF, thank you to everyone for joining and participating today, and enjoy the rest of your day.
Thank you. Bye-bye.
Bye-bye.